you ever found yourself wondering whether a change in your body is just part of getting older or whether it's actually something you should seek help for? Welcome to Mind Your Being. I'm Cass, and today's conversation is one that I think every woman needs to hear, particularly as we move through midlife and beyond. And honestly, I think this is a conversation many men would benefit from hearing too, to better understand and support their partners, mothers, sisters, daughters, and friends. When we think about menopause, most of us have heard about hot flushes, the night sweats, and the disruption to our sleep. But there's a whole range of other changes that can occur that often don't get talked about nearly enough. Things like recurrent urinary tract infections, bladder urgency, incontinence, painful sex, pelvic organ prolapse, and something called genitourinary syndrome of menopause, or GSM. The reality is that many of us women experience these symptoms, but because they can feel embarrassing or difficult to talk about, we often suffer in silence. And yet, as you'll hear today, many of these issues are incredibly common, and more importantly, there are effective treatments and support available. Joining me today is urogynecologist Dr Mugdha Kulkarni, who specialises in women's pelvic floor health. Together, we explore what's happening in the body during perimenopause and menopause, why these symptoms occur, when women should seek support, and the treatment options available. My hope is that this conversation leaves you feeling informed, empowered, and perhaps more comfortable having these discussions with your healthcare team, your partner, your friends, and the people closest to you, including the women you love and support. Please enjoy this important conversation. Thank you so much for coming on today. I really appreciate you making the time. I've asked you on to talk about women's pelvic health, such an important area, but I think it's often not talked about enough. And I myself have been wondering, where do we go to find good information on this topic? Before we get into everything, can you tell us a little bit about your work as a urogynecologist and what drew you to specialise in this area?
First of all, it's an absolute pleasure. Thank you for inviting me. You are right. Women's pelvic floor issues are extremely common, often underrepresented, and women tend to suffer in silence. So what you're doing is great, raising awareness, talking about things that women often feel uncomfortable talking about. So I am a urogynecologist. We are trained as obstetricians and gynecologists. We do 6 years of training and then 3 years of further subspecialty training across Australia and New Zealand. And we are trained to look after women's pelvic floor issues. Now, this encompasses problems like pelvic organ prolapse, when the pelvic organs or the vagina start to descend or protrude out, bladder problems, most common urinary incontinence, recurrent urinary tract infections, postmenopausal concerns around pelvic floor like genitourinary syndrome of menopause, which is often called GSM, and other things like painful sexual intercourse and post-delivery, so obstetric, postpartum concerns that women may experience. These are just some common conditions that we deal with.
It's such a broad spectrum, isn't it?
Absolutely.
When you were younger, is this an area you always knew you were going to go into, or did you decide while you were studying medicine?
Yeah, not at all, actually. I was not exposed to this side of medicine until second year of my training in obstetrics and gynecology. Most of our exposure during our training is mostly to obstetrics, so pregnancy, delivery, and care for pregnant women and delivery of pregnant women, delivering babies. But as a part of our training, we rotate through different parts of subspecialty or gynecology. And as a second year trainee, I came across this and I was like, wow, this is so common. And how come we don't talk about this? Even now in social media or on the internet, or even in terms of research funding, you hear so much about endometriosis, you hear about breast cancer awareness, ovarian cancer, but we hardly hear about pelvic floor dysfunction. Luckily, menopause is having its moment and lots of research and discussion around hormone replacement therapy, but we still are not talking about common problems like urinary incontinence and pelvic organ prolapse, which can be quite debilitating and affect one's quality of life. And unfortunately, women tend to suffer in silence. It's not a very comfortable or openly talked about issue. Not a lot of women want to come and say, I'm leaking urine, or something's coming down, or something's hanging between my legs. So people find it quite uncomfortable to talk about. And 1 in 3 women will leak urine. So when I was training, I was like, wow, this is really underrepresented. And I was drawn to it because we can really make a significant improvement in one's quality of life. It's treatable. People just think it's part of aging and it's normal. It's not normal. It's common. And because of that, people just think they have to live with it. They don't. We can offer treatment.
Thank you for normalising it all, because you're right, it is not spoken about commonly. I don't see this being talked about on social media. It really has a significant impact on women's health and well-being as we age. So I think we need to normalise it more to talk about it, and hopefully women will get some information here today but feel a bit more comfortable to go and see their doctors and get the referrals that they need, because, we shouldn't have to suffer if there's good treatments available.
Absolutely. Something as simple as genitourinary syndrome of menopause, or GSM, that you wanted us to talk about. As we age, estrogen levels drop, and a lot of women know of common symptoms like hot flushes and night sweats. But there are estrogen receptors even in the vulva, vagina, urethra, and the bladder. And you may experience symptoms like dryness, irritation, pain with sex. Bladder symptoms due to lack of estrogen can be frequency, going to the toilet frequently or urgently, all of a sudden having to rush. And recurrent urinary tract infections, quite common in postmenopausal women as well. Quick visit to your general practitioner to talk about treatment options. You don't have to see a subspecialist for something simple if you don't have one available in your region. A general gynecologist could also help you with these things. It's only when symptoms become chronic, they're complex, and you need surgical treatment, that's when you would consider seeing a urogynecologist.
I did notice I hadn't had UTIs since I was quite young, and then post-menopause, I got a few, like within a short amount of time. I did some research and found out this is quite common. I don't like taking antibiotics if I don't have to, but when you have the infection, you need to clear it. So I found out about vaginal estrogen. I think only in America, the FDA box warning on vaginal estrogen just got removed, but I think a lot of people think it's quite unsafe. My understanding is that not much of it gets absorbed into the body. Could you talk about the safety of it? Who could safely take it? And could you talk about that as a treatment option for the GSM symptoms?
Yes, so you first touched on recurrent UTIs. So anyone can have urinary tract infection. Recurrent urinary tract infection is when someone suffers from 2 or more infections in 6 months and 3 or more infections in 12 months. Often you might experience this in younger women when they start to be sexually active, and then postmenopausal women. It happens in postmenopausal women because of dropping estrogen, change in the vaginal microbiome, and change in pH. So the protective mechanism is lost. The job of vaginal estrogen is to restore all of this. It makes the tissue thick, elastic, more lubricated, and protects you from urinary tract infections. Now, vaginal estrogen has very low systemic absorption. In Australia, we get it in 2 different forms, estriol and estradiol. You can get it in the form of cream or tablets called vaginal pessaries. There are different brands. Common ones are Avestin and Vagifem. Often comes with an applicator, and some people might find using the applicator a bit uncomfortable or distressing. It's quite reasonable to just pop a little bit on your finger and put the finger inside the vagina. Recommended use is at nighttime so that it stays in, because during the day, if you start walking around, it might just come away. There have been lots of studies looking at blood levels in estrogen after vaginal use, and the systemic absorption is quite low. Women who have had history of breast cancer are particularly concerned around fears for risk of breast cancer around HRT, because whenever I've recommended estrogen, vaginal estrogen, women will be like, is this HRT? Technically, it is a hormone and we are replacing hormone, but it is not systemic. And when I say systemic, we talk about the patch or a tablet or gel that we give women for other menopausal symptoms, say vasomotor symptoms like hot flushes, night sweats, etc. It is quite safe to use because the systemic absorption is low. We have even given it to women who have history of breast cancer because the benefit might outweigh the risk. And sometimes women who have history of breast cancer, and if they've been estrogen receptor positive breast cancer, we have a chat with the oncologist, see what their recommendation is, whether we can use it for short time just to get over that acute episode of genitourinary syndrome of menopause and then wean it off. There are alternatives for people who can't use vaginal estrogen. Maybe they're allergic to it. Maybe there's too much anxiety and they don't want to use it. You could use things like vaginal lubricants or moisturizers. They may not have the same effect, but you may have some symptom relief.
A lot of people will take the traditional MHT, the patch, the gel, if they have a uterus, the progesterone tablet at night. And then on top of that, it is safe for most people. Am I right in saying it's safe to also use the vaginal estrogen on top
Correct.
of your other?
It is absolutely safe to use in addition to your systemic HRT. Your systemic HRT may not have the best effect on GSM because it needs local absorption in that area. So I will often prescribe both for women who need it, or if women don't need systemic HRT, we would just give them local. But it is absolutely safe to use in addition.
Okay, thank you. On top of the UTIs or the soreness with sexual activity, the frequency of feeling like you need to urinate even if you've just gone, what's happening there? Is that something the bladder's affected with the declining estrogen?
Yes, so that can be one cause of it, lack of estrogen as we get older, because there are estrogen receptors in the pelvic floor, bladder, and urethra, and sometimes supplementing with vaginal estrogen will help with those symptoms. But there are other conditions called overactive bladder, where the sensation coming from the bladder is excessive, or the bladder muscle contracts before you get to the toilet, and women leak urine. And that's why then there's increase in frequency of doing just in case wheeze so you don't leak. Often women will know every single toilet in town or in the supermarket. They'll pee before they leave, they'll pee before they start shopping, before they leave the shopping center, and as soon as they get home. Classically, women will explain the key in the door incontinence or urgency, where they were fine, and the minute they pull the key out and put it in the door, they'll get that strong urgency. Or when they're washing dishes or hear the shower running, all of a sudden they'll have a lot of urgency. It could be part of the GSM, or it could be an independent condition called overactive bladder.
So when you're getting that anxiety and that urge when you hear running water and stuff, is that when you should be seeking a consult to just check out whether it is GSM or something more?
Absolutely. And sometimes it can be a combination of both and hard for us to differentiate. Yes, that's definitely a good time to start seeking treatment because you want to try and arrest it at an early stage before it gets too worse. One of the first things we would recommend is seeing a pelvic floor physiotherapist to consider something called as bladder retraining or pelvic floor muscle training. Strength training is having its day in the social media these days, but we have muscles in the pelvic floor. We have muscles that are literally holding our organs in, and none of us are talking about strengthening those muscles. The vagina, the urethra, the anus and rectum are all surrounded by pelvic floor muscles, and they need exercise. They need strengthening. And that's where the pelvic floor physiotherapist is your first point of contact to help you engage those muscles. And easier said than done. Everyone's heard about them. People talk about doing a quick YouTube video. But a physiotherapist is someone who's specially trained in making sure you're doing them correctly, because doing them incorrectly can cause other issues like muscle spasm in the pelvic floor. So we don't want to replace one problem with another. So absolutely seeing a GP, seeing a pelvic floor physio, and then considering a specialist referral absolutely is not a bad idea.
As you said, apart from the vaginal estrogen for the typical GSM symptoms, seeing a pelvic floor physio is a great idea. Any other treatment options that people might not know about?
Yeah, so I touched upon vaginal lubricants and moisturizers. So after menopause, sexual activity can feel quite painful or dry, and I would often recommend using a moisturizer or lubricant at the time of sexual activity, or even other times when it is just feeling dry. There are many on the market. You want to consider water-based or natural ones. Sometimes silicone ones are reasonable too. Apart from that, there is another one called Intrarosa, which it is a DHEA modulator that gets converted to testosterone and vaginal estrogen. This is not on the PBS. It is slightly expensive, and we only have 12-month studies for this. So for women who have fears of using vaginal estrogen, this could be considered.
And is that a cream as well?
Intrarosa is actually not a cream, it's a tablet, it's a pessary.
Thank you. With the vaginal lubricants, are there particular ingredients that you recommend we exclude from those products? Because I know some of them can cause stinging.
Yes, the perfume-based, you definitely don't need any perfume down there, or glow-in-the-dark business. You don't want to be trying any of those things. The more natural it is, better it is, and water-based. And different people will they'll have their own preferences, so it's always good to consider different types. My favorite one to recommend is olive and bee, completely natural olive oil and beeswax. And most people who've used it have found it quite comfortable. You can order it online, or there are some stockists or chemists that are available that would deliver to you. But yeah, you want to avoid anything that has scents or chemicals that are unnecessary. Absolutely.
Yeah, as minimal ingredients as possible.
Absolutely.
I'll try and find a link for that product and put it in the show notes as well. Thank you. We talk about GSM for postmenopausal women. Can some of these symptoms start to happen in perimenopause?
Yes, as estrogen levels start to drop, women can experience GSM symptoms in the perimenopause. They might notice increased vaginal dryness or irritation that they didn't encounter before. It is absolutely reasonable to start using vaginal estrogen even in perimenopause. As women are using systemic cyclical HRT, they could consider this. Perimenopause is a difficult time to describe because we don't know when it starts. Anytime around menopause is perimenopause. And because the absorption is so low, it is definitely safe to consider.
So maybe for women to be aware of the symptoms and seek help based on the symptoms.
Yeah, there can be many reasons why women can experience itchiness in the vulval vaginal area. Common one being, say, thrush or fungal infection, candida. Women can have skin problems in the vulval region, say lichen sclerosus, lichen planus. Quite a common problem in postmenopausal women, lichen sclerosus, which is an autoimmune skin condition, which would need treatment with topical steroids and annual monitoring. So a lot of things can have an overlap. So examination is important, taking a full thorough history, and sometimes taking swabs to rule out any infections is important as well.
With that skin infection you were just mentioning, is that something you'd be able to see or just feel maybe?
So often the common infection we were talking about being candida infection, fungal infection.
Oh, no, the other one, the
Lichen sclerosus.
Yeah, is that something you would see visually as well?
Yes, and it is not an infection. It is an autoimmune skin condition. So there will be skin changes that can happen over the vulva that look like lichen sclerosus. Often it will have a figure of 8 appearance around the vulva. So the lips, the labia majora, labia minora, and perianal region. It can be anywhere from mild to severe, and it can progress if not treated. There's no cure for it, but it needs long-term management with corticosteroids. And if left untreated, it can progress and can cause change in anatomy of the labia, where you can have thinning of the tissue. Symptoms would be pain, irritation, itchiness, sometimes bleeding, and this can progress to squamous cell carcinoma. That's why it needs annual reviews.
Thank you. I hadn't heard of that one before.
Yes. And again, can happen in older people. With menopause, the appearance of the vulva changes anyway, just like how our face changes, our body is changing everywhere. So again, over the vulva, there will be normal menopausal changes that we expect, but on top we can get these skin conditions where there can be resorption of the labia and clitoral hood, and in really advanced cases the vagina might completely close off and women may not be able to pass urine, and that might need surgical correction.
Wow.
And I said, like, in up to 5% of cases it can progress to squamous cell carcinoma, skin cancer.
Okay. So best to get checked when women are feeling any symptoms.
Yes. Absolutely, because there can be a lot of overlap and not everything is just because of GSM. There can be more than one thing.
Yeah, thank you for explaining that. Just circling back to the vaginal estrogen and the UTIs, I've heard of a lot of elderly women in nursing homes getting recurrent UTIs. Is it well known among the medical community that it's safe to prescribe vaginal estrogen to a lot of those women to help them?
Yes, it's unfortunately recurrent urinary tract infection is a common problem in our older population, especially in nursing homes. It is common knowledge to use vaginal estrogen as prevention. One of the other strategies is using something called Hiprex, used with vitamin C to prevent urinary tract infections. It's an antiseptic. Increasing water intake definitely has evidence and shows reducing urinary tract infections. Often we are all used to drinking teas and coffees, especially in winter months, and not having enough water intake. There are small studies and not very high quality studies, but they do talk about high dose cranberry tablets and probiotics that also aid in prevention. But if we can't get on top of it with all of these things, then we have to put women on prophylactic antibiotics, so long-term antibiotics, but very low dose. And now in Australia, we also have a vaccine called Euroimmune vaccine. It is not on the PBS and can be expensive. It's a spray in your mouth for 3 months, and it does cover 4 organisms. So anyone with UTIs, the number one advice I would have is to definitely do a midstream urine test. We do want to see which organism is growing. We want to see what sensitivity it has. And we don't necessarily just want to throw antibiotics at people because obviously you'll go resistance. And now there are some guidelines that are changing where we are thinking of not necessarily, if there's a simple UTI, we just manage it with water, hydration, and addressing symptoms. Elderly women also get what we call asymptomatic bacteriuria, which means you're having a general health check and you've had a urine test done and it has grown bugs. If the person or the patient has no symptoms, we do not recommend antibiotics. So it is reasonable to consider that. Until recently, I don't know when, but not so long ago, we used to think urine was sterile. But that's not the case. There are bugs everywhere in our body, and the urine is not sterile and it can have bugs. But if you have symptoms, we would treat it. If it's asymptomatic bacteriuria, we would recommend not taking antibiotics.
With the Hyprex, you said, is that a drink solution that people take? Or?
It's a tablet. It's over the counter. You can also get a prescription. The standard dose is twice a day with vitamin C. The reason to use vitamin C is it lowers the pH and it works better. It's an antiseptic. Once it hits the bladder, it gets turned into formaldehyde and it kills any bugs if there are any. A bit more gentle than an antibiotic, I suppose. There are other things like D-mannose, which is basically sugar. And as you take it and pass it through your urine, the bugs get stuck to the sugar molecule and you pee the bugs out. Now, there have been head-to-head studies comparing D-mannose to prophylactic antibiotics, and there hasn't been much difference. Again, different women will experience different things, that it works for them or it didn't work for them. But these are some over-the-counter things that women can trial.
That's so important because the UTIs can become quite risky as we get older, if untreated.
Yes.
So with the vaginal estrogen, then say we start using it in perimenopause, menopause. Is it something that's recommended we could take for the rest of our life, or is it really just based on symptoms?
No,
How
you
do
can
you
take
look
it
at
for
it?
the rest of your life. There's no harm since the systemic absorption's so low. And if you're finding it helpful, absolutely safe to continue using.
Awesome. Thank you. That's good to know. So apart from these genitourinary symptoms of menopause, you've mentioned to me that there's a whole lot of other issues and symptoms and conditions that women can experience. What are some of them? What are some of the symptoms, and when do you recommend women getting help?
One of the common problems women experience is pelvic organ prolapse. So this is basically a hernia. It's a hernia of the uterus or pelvic organs into the vagina or through the vagina. Women will say things like they may experience symptoms of a bulge, lump, or heaviness. It may start off gradually where they may say it's more so towards the end of the day when they've been on their feet. Often women will say on days they're babysitting their grandchildren, they experience these symptoms because they're running around toddlers. Or on days they'll go and play a big round of golf and they're like, oh, by the end of the day of my game, I'm feeling quite heavy in the vagina. Now, it depends what is prolapsing. So if the front wall of the vagina is prolapsing, with it, the bladder flops down. And again, women may experience symptoms of frequency and urgency because they're not completely emptying their bladder. And this can also predispose them to things like recurrent urinary tract infections because the urine is sitting there as a reservoir for infection. If the back wall of the vagina is prolapsing and the rectum protrudes through there, women will have bowel symptoms like frequency or incomplete emptying of their stools, or the bulge gets worse when they're trying to open their bowels. Some women may also say they have to press on the bulge to get the stools out to feel completely empty. Sometimes the uterus comes down. They'll feel, I feel a huge lump, something hard. And depending on what level of prolapse they have, it can really affect your quality of life. Now, not all prolapse needs to be managed. Sometimes women come to me because they're like, I just went for a pap smear and I was told I have a prolapse. And that situation, if women are not experiencing any symptoms and if it's not affecting their quality of life, all I would recommend is pelvic floor exercises, avoiding constipation, and just looking after their general pelvic floor well-being. But if it's affecting their quality of life, then there are lots of treatment options, which are non-surgical and surgical, which we would individualize based on each patient's symptoms and needs.
With the diagnosis of that, like you explained the scenario with the pap smear where the woman wasn't even aware of it until that. But when women are aware of that, is that something a GP or a gynecologist diagnoses with a physical exam, or do you need ultrasound for that?
Prolapse is diagnosed by examination only. A pelvic ultrasound may be organized for other reasons, to rule out other pathology and to consider treatment. But prolapse is a diagnosis of clinical examination.
And is it something that only happens in postmenopausal women, or can younger women experience prolapse as well?
Yeah. So it's more common in older women. It's more common in women who have had vaginal births or instrumental births like forceps. But it can happen in younger women also who've never been pregnant, who've never given birth vaginally. It may be so because they suffer from connective tissue disorders and their tissue is very elastic. But the risk factors are more in women who've had more babies. And as we get older, the tissues get weaker, the collagen drops, we're all a bit overweight, we're all a bit constipated, and that puts us at risk of pelvic organ prolapse. Most times I've noticed people don't seek treatment because they are scared of surgery. They've heard of women who've had mesh and they don't want to have the same treatment. But that's not the answer. There are non-surgical options and there are surgeries where we don't use mesh. So there's no need for women to live with this problem in fear at home. Even just a chat to know what the options are is definitely recommended.
Thank you for explaining that. And even just having a chat, like you say, if women don't seek support, my guess is it's only going to get worse as we age, as the tissue gets less elastic.
Prolapse can wax and wane. You can have a good day and a bad day. If you sat all day on your couch watching Netflix, you might end up having a good day, but you've been active, you might have a bad day. As you put on weight or you get constipated, those symptoms can get worse. We used to think it was linear, but it isn't. But in the general sense, yes, our tissue is going to get weaker with age, and it's not going to go away on its own. It's not going to disappear. It's not going to rectify itself. There is a concept of using pessaries. Now, these are not the estrogen pessaries. These are devices. These are made out of silicone. They can come in different shapes and sizes, like a ring or a mushroom shape called Gellhorn or a cube. Basically, we insert it to hold things up in place. And that's pure symptom control. It's done in the clinic. It's not an operation. It may or may not work. There's no guarantees it will work. And it may take us more than one appointment to find the right size for each person. But it can significantly improve someone's quality of life. So fear of surgery should not be the reason women don't seek treatment, because there are non-surgical options that can really help people. Because if the prolapse is really advanced, some of these women can't pass urine. They cannot empty their bladder. And they're going to the toilet every hour or so and passing 5 or 10 mils. And then overnight, waking up many times to empty their bladder. It's really uncomfortable.
It's distressing, and it's impacting their quality of life. Yeah.
Affecting quality of life. And for elderly women getting out of bed, the risk is falls. And then, as you know, it's just downhill from there.
Yeah. Wow. So it sounds like there is a wide range of options, surgical and non-surgical. So encouraging women to at least seek a consult, have a chat. Yeah. Are there other conditions?
From pelvic organ prolapse, one of the other very common problem that really women don't talk about, and I find it fascinating because women are good at talking about things compared to men, is urinary incontinence. Leakage of urine is a big problem. You go through a supermarket, you will see these products, Poise and Tenia, incontinence pads, and unfortunately it's affecting our elderly women, and they're just really suffering in silence. One of the big reasons to end up in a nursing home is urinary incontinence. Now, urinary incontinence is basically involuntary leakage of urine. It can happen for many reasons. The two main common reasons are the overactive bladder, the one I mentioned earlier, where women have to go frequently, urgently, and they leak before they get to the toilet. And the other one is called stress urinary incontinence. That's because of the weakness of the pelvic floor. And when women have increase in abdominal pressure, say with cough, laugh, sneeze or exercise. Trampoline is a classic.
Trampolines are a no after having kids, I think.
Absolutely. Or star jumps. Yeah, so that's stress incontinence. Now, again, the symptom is the same. Women will come to me and say, I leak urine, and my job is to try and work out why you're leaking urine. Often women will have both. They will have stress incontinence and overactive bladder, and then we have to tease out which one's worse and address treatment towards that. Something as simple as what we're drinking. You know, sometimes women will come in with those giant Stanley cups and they're drinking 5 liters of water because Instagram told them to. And we probably don't. Well, if it's not causing you any problems, you can. But if you're having to wear 3 incontinence pads a day and you're drinking 5 liters of water, then something as simple as cutting it down might help. And bladder irritants, say caffeine, fizzy drinks, cola, soft drinks, they're completely unnecessary. Water
they irritate the bladder lining and cause that frequency urge.
Absolutely. And smoking, very dangerous for the bladder. Everyone knows about lung cancer, but smoking can predispose you to cancer of the cervix and cancer of the bladder. Wow. So, you know, cutting out on these things. So for overactive bladder, apart from changing what you drink, how you drink, some medications can be used once you have modified your lifestyle and seen a physiotherapist. And if the tablets don't help, and if it's really severe and refractory, we can put Botox in the bladder. Having said that, it's not permanent. Botox wears off, and it comes with its concerns as well. But there are things we can do to help women. The other one, the stress incontinence, the goal is to strengthen the pelvic floor, and that's where the pelvic floor physio comes in. Often women will be able to do a neck when they're going to sneeze and, you know, reduce the amount
of your legs.
You can use continence devices, again, like a ring pessary or a continence pessary to put pressure on the urethra, or surgery. Surgery is the mainstay for treatment of stress incontinence. And again, there are different types of surgeries women can choose from. Women hear about mesh and they don't come, but there are lots of non-mesh operations available that have very good success.
But for most women, unless it's really dire for the stress incontinence, you'd be seeking the advice and trying the pelvic floor physio
Everyone should
exercises
be doing
first.
pelvic floor exercises, whether you have leakage or you don't have leakage. Like everyone should go to the gym and exercise,
Yeah.
every woman should strengthen her pelvic floor. That is irrespective of surgery or tablets.
I am hoping to have a pelvic floor physio on here as well because, yeah, it is so important. Like you say, we go to the gym and do some resistance training for those muscles. We have other muscles that we can't see, right?
Absolutely. And they're very small muscles and they're hard to activate, and someone needs to teach us how to activate. And knowing the correct technique is important. And you don't have to see them long term. Even if you just see them once or twice, make sure you're doing it correctly. And then you're doing it at home, at a traffic light. You can do them anywhere, anytime, no equipment needed. So yeah, when I'm talking about treatment for overactive bladder or stress incontinence or pelvic floor physio, all of my patients, I recommend they see a pelvic floor. Even after surgery, I say at 6 weeks, okay, time to start your pelvic floor exercises.
What age for young girls do you recommend they start doing these pelvic floor exercises?
Absolutely. What happens with young girls is sometimes I have to send them to the physiotherapist for the other side. Sometimes their pelvic floor is too tight. It's hypertonic. So I will have women come to me and complain of pain with sex, and they may have a condition called vaginismus. Young girls might come and say, can't insert a tampon, or inserting one or removing one is too painful, or sexual activity is difficult, penetration is difficult, or it's painful. And on examination, you may find the pelvic floor is really tight. And then I'm sending them to a physiotherapist to down train the muscles. And that's why it's important to see them and learn the correct technique. If you're tightening your pelvic floor, you need to learn to relax them. Otherwise, you're going to end up here. Yeah, no one's too young. Absolutely. Like I said, it's like going to the gym as long as you're doing it correctly. You don't want to end up in a hypertonic pelvic floor. So then there are ways around that. So down training would be one treatment. And if it hasn't worked, then that's when I come in and I would put Botox in the pelvic floor muscles to relax those muscles to break the cycle.
Any other symptoms or conditions you'd like women to know that are quite common and that we can seek help for?
Yes, I think especially, my generation or the generation after me, I'm grateful that they are vocal. They like to speak up. They will not suffer in silence and they will seek treatment. But till date, even now, our older generation, our mums, our grandmothers, our aunties, they are very selfless, they're giving, and they're not good at complaining.
No.
Sometimes complaining is not a bad thing. It will improve your quality of life. So I want women to know, postmenopausal women to know, that sex can hurt after menopause and you don't have to suffer. There are things we can do about it, and there are very simple things we can do about it. Something as simple as vaginal estrogen and lubricant. Women think that painful sex is just part of life as you get older, and that is not true. We can help you, we can make it better, and you're allowed to seek help for it, and you're allowed to seek pleasure and enjoy sex. So please don't suffer in silence. Come, it's very simple things. There's no operation needed. Sometimes simple things can really change your quality of life.
And those simple things can often bring about a change quite quickly, can't they?
Oh, absolutely. And it's a simple thing. The change will happen within weeks, and it's not only good for, it has significant impact. It has impact on your self-esteem. It has impact on your relationships. It has impact on so many aspects of your life.
Yeah. I spoke with a relationship counsellor just earlier this week, and she said with older, like postmenopausal midlife couples, a lot of the time it does have an effect on the relationship because that lack of intimacy that can happen for various reasons, but one being which painful sex.
Yes. I mean, there will be discrepancy in the libido, so the drive. For female sexual function, it's a circle, with desire, arousal, and so on. The desire and arousal component drops. And again, that's a whole different chat. And we could talk about testosterone supplements, etc., to help with that. But it is such a complicated aspect of a couple's life as one gets older. And another aspect that needs to be explored and discussed, which even I don't have enough exposure to, is because most of my patients are women, is men with prostate cancers. And then when they have implants, and then how the sexual function is different afterwards. And maybe talking to a urologist or urological nurse who deals with that would be a fabulous conversation.
Okay, I'll note that down too, yeah. Oh, it's just, yeah, it's about quality of life, isn't it? But what I'm trying to do here, and I thank you for coming on, is to raise awareness, to help people know that these things can be quite common.
Yeah,
but like you said, for my generation and older, often there's a lot of guilt or stigma or shame, which there shouldn't be, because as you're telling us, it's quite common for women to experience maybe a few of these things or one of these things. But
absolutely. Yeah, absolutely.
Is there anything else you want to touch on there?
I think we've done a fair bit. Unless you want us, I think we covered prolapse, incontinence, sexual function, UTIs, GSM. We've definitely covered vaginal estrogen.
Yeah, which is good because
it's life-changing.
Yeah, well, I went out to lunch a few weeks ago, and I'm 51, and I think I went into hit menopause about maybe 45, 46, I don't know. And I have friends that are not quite hit menopause yet. They're talking about the hot flushes and stuff and the no sleep, which can be horrible as well. And I'm like, oh, hang on, girls, there's another thing you need to know about. But I won't scare you too much. There's treatment options.
Yes.
Just one last question on the painful sex. Is that going to affect all women or most women post-menopause? Not necessarily?
No, there will be some women who will have no problems at all, and some women will. And it depends from age group. When women are younger, we're worried about vaginismus, endometriosis, adenomyosis. As women get older, we would think about GSM, lichen sclerosis, vulvodynia, things like that. And there will be some women who will just cruise through it and no problem.
Thank you for explaining all that and taking out some of the fear, I think, because you've explained that there are non-surgical and surgical options, a whole heap of them. I was just going to ask, what's your advice? Because as we were saying, a lot of women will find it hard to discuss this. They might think they're complaining. What's your advice for women on bringing these issues or having these conversations with their medical doctors?
Oh, bring it on. Don't be shy. You need to empower yourself about your health and your well-being. No one else is going to do that for you. What's happening at this stage is, say, we have screening. We have cervical cancer screening. We have breast cancer screening. We have colon cancer screening with the fecal test once you're 60. Where is your pelvic floor screening? There isn't one. Hopefully in 10 years and 20 years, there might be something. But we don't have anything now. Take things in your own hand. See your GP. If you're uncomfortable seeing a male GP, see a female GP. You don't want to see a GP, see a pelvic floor physio. They are experts. They know what they're doing. We can't do this on our own as specialists. We rely heavily on pelvic floor physios. We rely on nurses, and we rely on our family practitioners, GPs, and general gynecologists. Everyone has specialty in this. The people that I've mentioned. Just go and have a chat. And if you don't want to have a chat, you can just say, I want to have a referral to this person and go see them. That is absolutely reasonable. Talk to your girlfriends like you are doing at a lunch. Everyone feels comfortable talking about hot flushes. Our bits are our bits. You are leaking from there. It's okay.
It's part of our body. It has such a significant impact on our quality of life.
It's funny. As humans, as the race, the only thing that's inevitable is we're going to die, and we don't talk about it. And we don't talk about weeing and pooing. Everyone does it.
You're right.
You know, it's a bodily function that happens multiple times a day. And as we get older, or even for some young people, it just doesn't work well. And if there's concerns, we need to talk about it.
Yeah.
We need to take the shame away from it, for sure.
Oh, I love that 100%. And women are living longer these days thanks to medical advancements and whatever. So we owe it to ourselves to have the quality of life that we deserve.
Oh, totally.
I appreciate you coming on to talk about all of this. It's great. Something I ask all my guests, do you have any rituals or practices or traditions that you use to look after your own well-being, to mind your being?
That is a good question. I'm going to be honest with you. I have, for the last month, definitely not been balanced. Life was taken over by too much work, and I got sick. Like, my body just said, actually, the only way you're going to do something is if I get sick, and I did. When I am in balance, the only way I am is with exercise. My mental health is so good when I exercise, and I'm a morning person. So I wake up early, go to the gym, and then it's done. That fresh feeling of exercise early in the morning and then taking the day head on is great. The goal for this year is to try and incorporate some mindfulness. So I am definitely struggling with that. My life is very go, go, go. And adding cardio and strength training is all good, but I also need to activate my parasympathetic system some way. And I think I'm looking at doing breathwork classes or yoga, maybe on a weekend or Sunday. And that is what I really need. My friends and family totally ground me, because at work, you're being bossy and giving out instructions, but at home, once you're there, your friends and family will ground you and tell you as it is. So that's very helpful. But I'm being honest, I have definitely not been in balance, and that's something I've got to work on.
Well, I appreciate your honesty, and that is a word that I use all the time, balance, because it's just giving a bit to each side. And like you said, sometimes you're going to give more to work, but then your body will pull you up and say, hey, you need to slow down. We need to listen to our body. So that's good. You've taken that on board. And the mindfulness stuff, I need to practice it more myself, but it is the thing that I think has helped me the most in my life with psychological flexibility, but with my mental health, because paying attention to the present moment for a while, it just helps give you a perspective on your thinking so you don't get caught up as much. It helps you relax your nervous system. It's all about doing a bit of each of the things, isn't it?
Helps you from moving from being reactive to reflective. Yeah.
Yeah. And like you said, in your job, high pressure, you're going to be reactive a lot of the time, but your body needs a bit of everything. So, yeah, good on you.
Well, thank you for doing this. I really appreciate you doing your bit to raise awareness.
Thank
Every little
you.
bit helps, and especially talking about these topics, which are quite underrepresented, is very helpful.
Thank you for saying that. And yeah, I'm just passionate about holistic health. And this one definitely is not talked about enough. But as we've stressed today, it impacts so many women, but it significantly can impact our quality of life. And it's great to know from you there's plenty of options available. So I encourage women to seek the help that they need, and also to share not just this episode, but other episodes like this or other information that you come across and find helpful. Share it with your girlfriends, your sister, your mother, because, yeah, we need to talk about it more.
Yes.
I think you probably covered this anyway, but if there's one message you'd love women to hear or take away from this episode, what would that be?
Look after your pelvic floor.
Thank you. I appreciate you giving up your time. We're recording this on Easter Saturday, so thank you so much.
No problem. Thank you so much for organizing it.
I can hear you're so passionate about the topic, and yeah, it's great that you've come on to share your information. Thank you.
Perfect. Thank you.
Thanks so much for listening to this episode of the Mind Your Being podcast. If you enjoyed it or found it helpful, please follow the show wherever you get your podcasts and share it with a friend who might enjoy it too. If you have a moment, please leave a quick review. It really helps others discover the podcast. Thanks again for being here. Take care, and until next time, mind your being.